Nearly 50% of patients referred to an electrodiagnostic laboratory for a clinically suspected radiculopathy return a completely normal study. Here we see the typical finding, an entirely normal slat sensory nerve action potential, or SNAP. Despite this high rate of negative test returns, these patients are usually experiencing genuine pathology. Their primary complaints are dominated by radiating sensory symptoms and pain. The issue lies in the anatomy of the nerve fibers. The unmyelinated C-type sensory fibers responsible for transmitting these pain signals are too small to be interrogated by routine nerve conduction studies. Referring providers often send patients to the lab expecting that standard surface stimulation will easily validate the patient's radicular pain. In reality, routine nerve conduction studies have severe limitations in diagnosing radiculopathy. Their primary utility is to exclude alternative peripheral mimicking disorders, like carpal tunnel syndrome or a localized polyneuropathy. To actually confirm a radiculopathy, the diagnostician must shift tactics and rely entirely on the needle electrode examination, or NEE. Successfully executing the NEE requires the examiner to map a precise spatial triangulation of affected myotomes and then evaluate those findings against a rigid biological timeline of nerve degeneration. Electrodiagnosis generates a functional snapshot, requiring the examiner to actively engineer the study to navigate the anatomical blind spots inherent to the spinal cord. The high rate of negative studies is a direct consequence of the physical location of the nerve compression relative to the cell bodies. In this cross-section, ventral motor and dorsal sensory axons converge. The dorsal root ganglion houses sensory cell bodies at the intervertebral foramen. Disc protrusions occur intraspinally, pinching the root proximal to the ganglion. Thus, the DRG and distal sensory axons remain structurally intact. Since the cell body is still nourishing the distal axon, Wallerian degeneration does not occur in the periphery. When you stimulate that nerve distal to the spine, the sensory nerve action potential reads as completely normal. There is one major anatomical exception to this rule: the L5 and S1 dorsal root ganglia. Up to 38% of L5 dorsal root ganglia reside entirely within the intraspinal canal. This intraspinal position makes the cell bodies uniquely vulnerable to central compression from a herniated disc. If an L5 dorsal root ganglia is crushed intraspinally, the cell bodies are directly damaged, causing Wallerian degeneration down the leg, resulting in a completely absent or low-amplitude superficial fibular snap. In almost all other cases, a normal sensory nerve action potential does not mean the root is healthy. It simply proves the lesion has not destroyed the extraspinal ganglion. While sensory responses are protected by the ganglion's location, the motor ventral roots originate within the spinal cord itself, meaning they are directly compressed. Yet standard motor nerve conduction studies also frequently return normal results. Intraspinal lesions, like a protruding disc, typically press against the nerve root rather than severing it. This pressure damages only a limited fraction of the traversing motor nerve fibers. This animation shows why motor studies miss partial damage. To record a reliably abnormal drop in amplitude on a compound muscle action potential, or CMAP, at least 50% of motor axons must be lost. Anything less generates a completely normal waveform. To bypass the peripheral nerves and test the root directly, examiners often use late responses, specifically F waves, which send a pure motor arc up to the spinal cord and back. However, F waves lack diagnostic sensitivity. The microscopic delay caused by the narrow, compressed segment of the root is diluted by the much longer segment of normal conduction time as the signal travels all the way down the limb. Surface stimulation cannot reliably detect fractional motor loss, nor can it detect preganglionic sensory damage. Because of these physical limitations, surface nerve conduction studies are entirely insufficient for ruling out a radiculopathy. Because surface conduction studies lack the necessary sensitivity, diagnosing active motor axon loss requires inserting a needle directly into the muscle tissue during the needle electrode examination. The American Association of Neuromuscular and Electrodiagnostic Medicine has established strict criteria for this procedure. An examiner cannot diagnose a radiculopathy based on a finding in a single abnormal muscle. To meet the threshold, abnormal activity must be found in at least 2 different muscles sharing a myotome. Using this matrix grid, notice the critical caveat. these two muscles must be innervated by different peripheral nerves, like the musculocutaneous and radial nerves. By isolating abnormalities to multiple, distinct peripheral nerves that intersect at a single spinal root, in this case C6, the examiner mathematically proves the lesion must be located proximal to the brachial plexus. When an examiner correctly executes a standard 6-muscle screen covering all common root levels, the sensitivity for detecting a radiculopathy reaches up to 99%. To definitively isolate a lesion to the intraspinal space and rule out a plexus injury, the examiner can also test the paraspinal muscles, which branch off immediately after the nerve root exits the foramen. Testing the paraspinals has precise limitations. The segmental innervation to these muscles overlaps considerably, meaning an abnormality detected at the C7 vertebral level does not guarantee a C7 root pathology. There is also a strict surgical contraindication. If a patient has had prior posterior spine surgery, the paraspinal muscles often suffer permanent iatrogenic denervation. Testing them will yield unreliable results. The needle electrode examination relies on precise anatomical localization. A confirmed radiculopathy is established by identifying the common spinal root shared by multiple affected muscles. The spatial matrix of the needle examination provides the location of the injury, but this map is useless if performed at the wrong time in the disease life cycle. This timeline reveals a blind spot. In the first 21 days following an axonal lesion, needle examinations appear normal. At 3 weeks, Wallerian degeneration reaches the muscle and fibrillation potentials appear. Because motor unit action potentials retain normal shape, this is defined as acute, active. Between 6 and 26 weeks after the injury, the reinnervation phase begins. Surviving motor axons attempt to rescue denervated muscle fibers by extending new branches, a process called collateral sprouting. As these new collateral sprouts form immature neuromuscular junctions, the morphology of the motor unit action potentials changes, becoming highly polyphasic and electrically unstable. As these reinnervated motor units mature, they take on their final structural state. Looking back at our timeline, you can see these waveforms become high-amplitude, long-duration potentials with a reduced recruitment pattern. When these specific waveforms are present, the lesion is defined as chronic. Examiners combine these terms to communicate the exact state of the nerve root. Finding chronic waveforms alongside active fibrillations indicates a chronic active lesion. Finding chronic waveforms with no fibrillations indicates degeneration has stopped, defined as a chronic inactive lesion. Failing to use these exact standardized qualifiers directly causes misinterpretation by referring physicians, leading to confusion over whether the root injury is still actively occurring. The entire diagnostic framework relies on this two-part structure. Nerve conduction studies clear the peripheral mimics, while the needle examination triangulates the damaged root in both space and time. Even with perfect timing and spatial mapping, an electrodiagnostic study only interrogates the motor fibers. If a patient presents with a severe sensory predominant radiculopathy, a completely normal EMG never fully excludes it.